Welcome to the 2020 Virtual National Institute on Healthcare Fraud, sponsored by the ABA Criminal Justice Section. This session is entitled Enforcement and Compliance in Telehealth. Presenting this session is Julian Rivera. Julian is a partner at Husch, Blackwell, LLP in Austin, Texas. Julian, you may proceed with the program.
Thank you, Donna. Welcome, everyone. What a strange thing it is to be having this conference with virtually. As many of you know, this conference was set up originally to really be a small and intimate in-person event, and so we're now doing this, and I think the content so far has been great, but I want to make sure that this is as interactive as y'all can make it. So I'm going to be asking some questions periodically, and those questions are designed to kind of stimulate the chat box and see if we can get conversation going over on the chat box. Both in questions and the chat box, I'm limited as to how much of it I can look at and engage with, but I think it would be helpful to have separate conversations going on in the chat box, or at least consistent with what we're doing, with what my part of the presentation is. So next slide. So I'm very, very happy to be here. There are 4 things that we are going to set out to do today, to go over. And those are that we're going to look at the expanding practices and bases for telehealth services. And we're also going to look at the reimbursement by federal programs and private healthcare plans. Third, we're going to look at telehealth business models that have resulted in criminal or civil liability. And then fourth, we're going to look to what the future may hold for these services. Throughout the presentation, there are links. We're going to be going to some of those links live. And then there are resources at the end of the presentation that have links in them. And so I commend all of those to you as a resource looking back. Next slide. Okay, so let's be clear about the telehealth framework. As many of you know, the telehealth is a generic term, and it involves a number of different things, from telemedicine to telepsychology to telephysical therapy, teleoccupational health, whatever. And telehealth speaks to that whole universe. The basic idea of telehealth is that it is services that would otherwise be covered or otherwise available in a face-to-face meeting. And there are 4 different ways, there's 4 different modalities, if you will: audio alone, two-way audio visual, store and forward, and remote patient monitoring. Store and forward is like radiology, where the image is stored and asynchronously looked at by the provider. We're now at a point where video and other data gathering resources are available to package the telehealth visit, the telemedicine visit, for later viewing by the physician, and that is actually a real source of compliance risk if it's not handled carefully, but we'll get to that particularly. What I wanted to start with, though, is, all right, let's go back to this and yeah. Well, let me tell you what that video was. That video was put together by the Telehealth Resource Center in California, and it was a video interview following a patient around a rural setting. And this patient had struggled with mental illness before, specifically depression, before COVID. And the clinic where she was getting care had very limited mental health services. And so the video takes you from her home to the clinic, and you see her meeting with her providers, and you see them in person, and each of them are telling their story about what it's like to care for her and how valuable the service has been. And I think what's particularly compelling about it is that it is in a rural setting, it is in a Native American setting, and it's in a clinic that is really working hard to provide services. And the ability of this patient to go to that clinic and get the care that the patient needs via telemedicine is really, it's as you could see from the video, and you'll be able to click on that out of the slides when you download the slides for yourself. But the video lays out, the story is that this person was really at the end of her rope and pretty hopeless. And the opportunity for her clinic to get her the care that she needed changed her life. And she presents in a really positive and bright way, so that makes it even more compelling. Another thing that's compelling about it is what you don't hear, which is, or don't see, and that is that she has to go to her clinic to get the care, because the clinic is the originating site for the technology. So there's no explanation in the video why it is that they didn't connect to home, which you can now do under COVID. But it really makes you feel the power of telehealth. And if we kind of extend that one more step, telehealth has shown us that COVID, particularly, and telehealth secondarily, has shown us that we have massive healthcare disparities, particularly technical healthcare disparities. We have entire communities that don't have sufficient broadband to get the wonderful, now reimbursable telehealth services. They can't get it. They don't have the signal. And we have these technology wastelands are in the urban setting, where people of certain demographics just don't have the bandwidth, the signal to be able to engage in telemedicine. And that then brings us to the actors in the telehealth environment, which is this slide here. And that is that the ecosystem, this is a limited drawing of the ecosystem. The idea here is that it is multiple providers and the patient, and they're all communicating using technology, using email, using multiple different platforms. And now we have payers deeply involved in the selection of that platform and in the standards of what they will pay for. We have providers who are working with multiple vendors and multiple pieces of technology trying to pull this ecosystem together. And then we have the vendors who are coming in and engaging in contracts and then really looking to leverage software. They're not selling a service, really, no matter what the contract says. It is just software. And the telemedicine, the provider care, is actually very separate from most of the vendors. Many of them have it combined, but the basic technology doesn't have any investment in anything other than security and functionality. And then you have the consumer, which I think really drove the explosion of COVID-19 telehealth usage, because we had consumer platforms, that was technology platforms that were already built out and working and engaging so many of in the population. And rather than using the only way to open up telehealth to those who could get it was to use the consumer platforms. And that, of course, those platforms were the most comfortable for consumers anyway. Next slide. Next slide. So what happened was that we stress tested our virtual health infrastructure. And what does that mean? That means we had all these different components. We had different technologies we were using different vendors, we were crunching data, we were using telephone, limited, not very much in terms of reimbursement. And we were using methods of patient flow and workflow, and we were slowly converting from bricks and mortar to virtual, but there wasn't any, there was no catalytic force. We were still buried in decades old, in many cases, regulations and policy that really kept us from figuring out that telemedicine will work. So the Hipaa enforcement relaxation that happened, given the reliability of consumer and electronic medical record platforms, was a huge opening, because what people heard when the Hipaa enforcement relaxation happened was not that, okay, there's going to be less enforcement, but that was the blessing of all of those platforms in terms of being secure and keeping privacy. And that alone was a huge change for the regulators to essentially admit that the regulations and the culture that was holding back the use of that technology was artificial. And so the question now is, do we have resultant problems because those regulations were lifted? And we'll get to that in a little bit. And the answer to that is, in general, no. The other thing that really happened well with COVID-19 was a number of organizations. Every player in the healthcare system, vendors, professional associations, government, quasi-government, everybody weighed in on standards and techniques and checklists in order to do telemedicine well. And so we had a conversion from really no telemedicine, or very, very limited telemedicine, to completely open in a matter of weeks. And so you had healthcare providers having to make the transition completely to telemedicine. And that transition happened without any horror stories of somebody being ripped off or somebody being hurt. Again, there's some exceptions, and we'll get to that. My point is that the entire healthcare ecosystem came together, including health lawyers, came together and built the tools and education and instruction to help make that to help make it work. Next slide. So we've talked about already the catalytic effect. I want to jump here to the fourth bullet here, which is the user interface and functionality similarities across teleconferencing vendors became clear. There was refinement in the privacy part and the breaches that happened, particularly with Zoom and others. I think pretty well everybody suffered at some point with some security issue. Some very minor, some really threatening to the platform, to the integrity of the platform from a business standpoint. And I think what we saw was that the basic platforms are the same, and they were adjusted to the extent they were adjusted towards what are really common standards. The user interface that we're using for this webinar right now it mimics or is very similar to the platform that any other platform that we'd be using for this. The level of security, the level of reliability changes from one to one, but the user interface is something that we all had to learn to engage just in our professional lives. And that made engaging in telemedicine much less intimidating to consumers. It was, okay, well, a video call. All right, I'm now doing these with my family, so, here we go. The other thing that it opened up, and I mentioned this before, is audio. The question of, can you provide care, and what care can you provide by telephone alone? And we'll get to that. That's a really important modality to kind of put in the corner of your mind and follow up on. The other thing is that the consumer privacy security practices and laws pretty well held up. There wasn't a lifting of Hipaa. There was a relaxing of the prosecution, and although or the enforcement, and although that was a broader signal to many, it was a very clear signal to folks that, hey, we still want our regulatory structures to stay in place, and we want you to respect them. And that was a reminder that, that's the regulatory structures are useful. So let's not just throw them away completely, because we got some responsibility. So it was a really interesting mix of adjustment, the different motivations for adjustment. Next slide. So the easing happened, and here's just a quick timeline of, you had the president declaring the state of emergency in March, a national state of emergency. You had the public health emergency declared in January, or at least effective January. The CARES Act relief included telehealth provisions. And then there were all these sets of federal and state waivers that I'm sure everybody with us today knows about. And then health plans reacted by making telehealth more widely available and offered even free services during the time period. We're finding that enforcement and decisions by payers that are conservative are still happening. Quick examples are the uproar about the charges for COVID-19 testing, uproar going to Congress, and the community and consumers being really upset. And what just using that as an example, there was this ecosystem of providers engaging partners, if you will. So providers, maybe a freestanding ER, having patients go to a particular lab that says that they can run the test. But there was a question of, well, is that lab in network? How much is that lab going to charge? And don't we expect that the government's going to pay for all of the COVID tests anyway? So in the middle of that became a real uproar about the conduct of well-meaning people that just didn't think they had the responsibility, and they didn't, to understand the entire payer horizon at a level that now consumers and regulators and legislators are assuming should have existed. So there's a lot of hindsight 2020, and I think that it speaks to the integrity of the system that we have those in isolated, they're isolated examples. Next slide. So here are the specific 1135 waivers, and these are the waivers that CMS issued for Medicare. So just running through this list quickly. there was the removal of the rule and originating site limitations, and as many of you will remember, there was a limit that CMS would not pay for visits that were not in the rural setting, and they wouldn't pay for visits where the originating site, that is where the patient is, unless that patient was in an approved setting, a clinic of a certain type, and that then was lifted, and patient providers could go straight into the home. That, in my view, was the biggest change and the quickest change, and it was the one that was the least risky, because in my view, the requirement, the restrictions that were keeping care from going into the home were less about good care and more about the concern that there was going to be an escalation in utilization if the floodgates were opened. And then there was also the concern that, we're going to increase fraud, an opportunity for fraud if we let it go into the home. And from a technology standpoint, that just wasn't credible, as we see now. It didn't increase the risk of fraud. In fact, it decreased the risk of fraud, because now we have systems that are repeatedly improving and taking in data about the integrity of home visits. So we have lots and lots of data to show that good providers of every type have used telemedicine. They've used it effectively into the home, and they did it without a massive outbreak of fraud. Again, I'm going to get to the specific examples of where fraud has happened or is alleged to have happened. So the waivers were not limited to the services related to COVID-19, which was an interesting decision of, okay, we could lift the waiver, and we could put in waivers if it's for the care of COVID-19. And I think in many ways that's where things were headed for a period of time. And then folks realized that there was just no way to make the distinction, that the country was going to need telehealth services without artificial or outdated limitations. So the direct supervision, a big deal. The idea that that a physician can supervise someone at the originating site who's giving care, but here we're talking about the supervision of the individual specifically. Can you do that by telehealth, or do you have to be there? And they lifted that limitation. Then we got in the confusion of virtual check-ins versus digital e-visits, coverage for remote patient monitoring. That's still a real jumble of opportunities and limitations. But again, associations stepped up and clarified some of that for us, and I'll share that with you here in a bit. And then the federal requirements for professional licensure eased, and that required a easing at the state level. And then CMS ultimately encouraged the states to really lighten up on that. But we did not see an elimination of the requirement for a license in the state where the patient is located. What we got was a lightening of what it takes to be registered with that state's licensing board during the time of an emergency. Next slide. This, from my perspective, is something that came out. When it came out after most of the waivers, but there was still some waivers coming, and we were not altogether clear about what the states were going to do that worked with what CMS was trying to do. And so CMS put together with there were a number of people who helped work on this, but they put together a guidance for state Medicaid programs, which you would think on the surface is just a regulatory thing that is nice if you're a Medicaid administrator, but not very practical. And it did two things. One is it really laid out the policy considerations that need to happen. It articulates them clearly. The idea of what does it take to be licensed in the state and why, and should you use telephone, or should you, or what modalities, and how do you approach that? And that tool, while it's good from a policy standpoint, it's also good from a compliance standpoint, because there are lists and organization of analysis that are really helpful to help people visualize and create the structure for compliance and the scaffolding that goes into what compliance is about. So this is a hyperlink to that toolkit, as well as the supplement that they did. Came out about 3 weeks ago, maybe 4. But I commend both of them to anyone interested in trying to learn what's going on and how to run a good program. Next slide. So the DEA, many of you know that the DEA by statute, had a restriction in the Ryan-Haight Act that disallowed the prescription of controlled substances via telemedicine. There were many state corollaries to this where pain couldn't be treated by telemedicine, pain period, or chronic pain particularly, but whether controlled substance or not, you couldn't treat pain via telemedicine in some states. So the DEA, and this was early in the process, came out and said, okay, well, if it's for a legitimate medical purpose, and we're talking about audio-visual, real-time, two-way interactive system. So that's not asynchronous. That's not phone. It's the full boat of telemedicine. And then in compliance with federal and state law. And what that did was it set it up so that folks could use telemedicine, and the way they structured it from a statutory standpoint might be academically interesting, but the bottom line is they lifted the limitation. They did it early, and there hasn't been any indication that that was a problem. Now, part of that is because the state stayed in the game and continued to regulate their side of it. But we had been struggling as a country with the DEA needing to make. Congress had ordered them to make rules, to issue rules for the use of telemedicine, and that was due last fall, and the DEA just didn't do it. And then here we have, as complicated as that may have been, well, let's just drop it, and let's make sure we've got we have a net, and the net is the audio-visual real-time two-way interactive communication system. And I've got to believe that they realize that anybody who's prescribing through this modality, there's going to be an electronic trail to follow if there's a significant problem that's raised by the lightning of this regulation. An issue that didn't get a lot of attention is that a provider has to have a registration, not just in the state where they practice, but or their home state, but they have to have a registration in every state that they're going to be prescribing. And then the question is, what is that location in that state? And where are you registered to in your home state? And can that be your home, or does it have to be a clinic? And it was determined that it could be where the doctor is actually physically located, but there also needs to be a registration in the state where the patient is located, and there has to be some physical address that is pinned to. We don't have a lot of clarity about that. I hope that that's not going to be a compliance issue down the road, but it is really important from a compliance standpoint to really be thoughtful about analyzing where the registrations are and what those registrations are for and what the scope is. Because every time you get a registration in a state, you're picking up that state's controlled substances laws too, and probably prescribing laws too. In fact, they're prescribing laws. And so it adds an element of complication. The good news there is that the states are doing that in a very, very similar way. There's not a lot of variance from state to state in terms of the core regulation of the controlled substances stuff. They follow the DEA. They generally follow the DEA's lead. Next. So I've talked a good bit about the waivers on the Hipaa compliance. It was interesting that they set up this waiver. The Office of Civil Rights did for the quote unquote good faith use of telemedicine platforms, even if the services are not provided through a Hipaa compliant technology. So that was a really important piece of, okay, well, we're not going to try to figure out whether it's Hipaa compliant. We're just going to use it. And we're going to want to be responsible and follow make sure that the technology is safe, that it is secure, and it's keeping privacy the way it should. And I think what the recognition here is that if there is a reasonably secure platform, communication platform, that's acceptable. The niceties of HIPAA compliance, I think, and I've long thought this, are really irrelevant, because if you've got a good, secure system by industry standard, then that's going to meet what HIPAA requires. Again, there are fine pieces that I'm going to get to in a little bit, but the fact of the matter is that an arbitrary requirement that all of this technology had to be following regulations that are decades old. Again, it was getting in the way, and when it was lifted, there was a whole lot more use, and we've seen that use evolve into a good thing. There are special rules for substance abuse patients still in place, but that's the ever reality that there are two different sets of privacy rules for everything other than substance abuse patients and substance abuse patients. And then this was for several weeks we were wondering, okay, well, these are nice waivers, but when we do the business transactions that it takes to handle what it is that we're facing, what's going to happen with the key TAM relators? What's going to happen with OIG? And for the government to come and say there's not going to be enforcement action under the anti-kickback statute, and particularly for waiving or reducing cost sharing for telehealth, that was a huge signal of, okay, that's the argument I'm going to make when there wasn't perfect clarity on whether there was something that was appropriate to do under the circumstances of COVID. I'm going to look at what the waivers were and what they covered and what their intent was. Now that's not going to sustain us, frankly, to today, but that did help us kind of ease up on telling clients that they really couldn't do anything because we didn't know what the hell was happening. We saw the entire health law community relax and say, look, there's some risk here, but you need to get to work, and you're telling us you need an answer and you got to go, and here's your answer. Next slide. Fraud and abuse waivers. These are the waivers that were that I was talking about, here are the specifics, and they are that hospitals and other healthcare providers can pay above or below fair market value to rent equipment or receive services from physicians. So the scope of that, duration, where those deals would be, that was unclear. There's still some spots that aren't clear, but in general, at least what I've been seeing is the folks have been able to kind of settle into right and wrong, what's appropriate and what isn't from a legal analysis standpoint. So where there've been gaps, it's been interesting to see that people respect what the policy is and are trying very hard not to overreach. And there's also another really important lesson from a compliance standpoint to all of this, and that is the importance. And we have the relief funds are also indicative of this principle. The principle is that whatever you decide is your interpretation of the law for what you're fixing to do in this gray area, document it. Document that analysis and document it so that you can use that analysis transparently with a governor, with the government, or with a payer, or with whoever has a question. You can see exactly what the logic was and where the integrity is. And so what that documentation needs to include from a legal opinion standpoint is it needs to say, okay, here's why it's okay, and here might be some risks. So there are some situations that we just can't give a clean opinion, an unequivocal opinion, to be relied on for use of reliance on counsel defense. But from a practical standpoint, if you can articulate what that defense would be in your communications to the client, in your presentation of those opinions, if you can accomplish that from a business standpoint, right? Not in a theoretical, okay, well, this is what the regulation says, and this is what it was in the past, and just a technical analysis, but shifting that technical analysis to an operations-ready analysis. Then the compliance team can pick up that analysis, and that analysis should give the compliance team signals as to what they need to be looking out for and what they need to be able to have the organization or the provider prove if somebody comes to ask questions later. What this has done is it's forced all of us in the system to stick our necks out and to articulate our opinions, knowing that they could be wrong and they could be interpreted differently. And so it's been a very delicate process of understanding all of the different components in health law and then coming down to giving opinions and direction to clients that are effective and useful and timely. The decision-making of analysis, everybody had to up their game in terms of learning the law because the law was constantly changing. It was fun to watch that. The second point here is healthcare providers can support each other financially to ensure continuity of healthcare operations. This is a good place to really put a fine point on my compliance suggestion, and that is that they can support each other financially to ensure continuity of healthcare operations. So we need to make sure that it's each other. And if we're talking about a third party, well, how does that play into it? And then it's financial, and it is to ensure the continuity of healthcare operations. So if every business decision was articulated why the decision was made how the decision was made, rather, in the service of the continuity of healthcare operations. That needs to be specifically articulated in real time so that you don't have to go back and ask people to remember and testify about what they were thinking back during an emergency where everybody was under a great deal of stress and trauma. This is a second reference to, we talked about it with OCR, but this is a second reference to the OIG and AKS waivers. Donna, why don't we see if we can show the website there, American Medical Association COVID-19 coding scenarios. Nope, doesn't look like it. Let's bail. What that is, and again, that's in your materials. What that is a PDF that was put together by the AMA that lays out a really nice analytical framework for sorting out all of the different components when it comes to telehealth coding during COVID. And frankly, it was one of the best. I wanted to take you all through it because it was one of the best presentations of that complexity that I had seen to date. And it's simple. There's only 6 slides in there. And it's graphic, but it's also organized in a way that really helps folks look at things analytically. And fundamentally, I think what it did was it showed, hey, look, don't be afraid of this. You don't have to go and study the regulations and go through an 8-hour health law course about telemedicine or an 8-hour coding course. We know that nobody's got the time to do that. Here, this is what you use. And so this was a really good center of gravity for conversations within providers and payers alike to be able to visually look at something and adjust their own analytical algorithm, their or institutional algorithms and flowcharts. These scenarios that they lay out is a very good way to lay out your compliance structures, which is where I'm going with all of this, is that so many of the tools that got laid out during COVID are just every single one of them. You can pull out really good lists, really good elements, really good documentation standards, really good sources for keeping data, certain kinds of data. There's just a wealth of resources out there that really help compliance efforts to really make the compliance program operationalize the compliance effort. So rather than it just being slapped on top, which everybody hates and nobody's convinced is particularly effective, we now have a number of different tools. And again, I've shared at the end of this presentation is a list of resources that can be used for lots of different purposes. Next slide. Okay. Let's take a breath here, just long enough to take a look at the time. We're a little less than an hour in. We're going to go for another 25 minutes or so, and then open it up for questions. And feel free to toss in a question or a chat as we're winding this up. So enforcement trends. Next slide. Okay, so I'm going to structure this in the most obvious fraud to the most subtle, and where there's likely not more than abuse. And that I think gives a good paradigm for analyzing risk and stratifying risk, for that matter. So there were pre-COVID, there were multi-billion-dollar alleged fraud schemes. In many of those cases, the main players have entered guilty pleas. There's 3, maybe 4 of these big fraud prosecutions, and yes, they are in the billions of dollars. For somewhere between 3 and 5 billion apiece. So, what do those schemes have in common? And again, these are allegations, or I'm going to presume they're allegations. But the prosecutorial theories here were that there was telemedicine used to fraudulently generate DME orders, fraudulently generate genetic testing, and fraudulently generate lab testing. After you see the analysis here, you'll see that there could be another piece on here, and that is prescribing. And so you've got pharmacies, pain creams are an example. So the commonality of all these schemes is that they are targeting healthcare inequities. So they're using telephone, TV advertising, a good deal of internet trolling and searching to generate patients of a particular profile. So one example is that they ran, I'm forgetting which one of these it is, but it is that they ran ads on television that were directed to the homebound elderly. And the idea was that if you've got knee pain, and you haven't considered having a brace for that knee, well, you ought to call us up and the brace will be free. That's the implication of the advertising. Back braces, same thing. So what would happen is that consumer would follow up with the business entity that is gathering these patients, and there would be an intake by someone who's not a medical professional, but going through a script to do a medical intake. There are set questions that they're asking. Do you have a history of heart disease? What's your age? What's your weight? Do you know a blood pressure? They filled out as much information as they thought. It was very carefully tailored to get information that would be useful to support a prescription, but also not so much information that it looked like they were taking on responsibility for anything other than evaluating whether the patient would benefit from the DME. So in many of these schemes, there's an initial intake person, then there's a follow-up from a quasi-clinical person, again, generally not even a clinical person, but it sounds like it to the patient. And then there's a third level of a clinical person, and that clinical person, it could be a nurse, but generally that clinical person, well, let me back up, could be a nurse facilitating the engagement of the physician, or it could be a prescriber, a mid-level or a physician. And what comes to the physician is this really nice medical record that's been put together electronically based on 2 interviews with the patient. And the doctor has the opportunity to engage in yet another telemedicine visit with the patient in order to make sure that this order is appropriate. The problem is that the doctors didn't know that they were just another clogged gear. that they were just a piece of the puzzle, that there were physicians, a limited number, but there were physicians around the country that were getting licensed in multiple states, so they thought they were okay, and they didn't know the size of the scheme, and they lost sight of, many of them lost sight of the integrity of making decisions about braces, as innocuous as those might sound, and as credible as the medical record indicated the patient's need was. They just didn't appreciate that they were part of the physicians particularly didn't appreciate that they were engaging in a fraud the size that it was. I mean, who could believe that you're involved in a $4 to $5 billion fraud? What doctor, they're going to want a bigger piece of the pie than what they were getting paid, I would think. So what this did was it targeted underserved communities, because those are the people that are going to respond to these kinds of ads. And what the government saw was that they saw utilization going up. They were able to, at some point, track through the scheme and find the entities that were selling the DME and work backward to find where the prescribers were, and then working backward to what the telehealth company, so to speak, was doing. All of that can be done without leaving your desk if you've got the right clues. The investigator. And the third commonality here is that there was that it was direct to consumer. And so what direct to consumer means is that it's directly from the provider to the patient, and there's no intermediary relationship. So there's no insurance company, there's no bricks and mortar healthcare provider. It's just as clean as you can get. And I'm going to talk next about what direct-to-consumer care looks like that has integrity, but and it's important to understand those so that we can understand what fraud is as opposed to high-integrity direct-to-consumer care. Again, elderly and disabled, it generally is independent prescribers that are not part of a group or any organized provider organization. It's not longitudinal, so it's just this episodic, okay, great, nice to meet you, here's a brace. I'm not your doctor anymore, good luck to you. Multi-state, these very rarely are limited by state, and they use TV ads and phone banks to accomplish this. There's a way to do this with integrity, and unfortunately, that's in the cases like these. It's very easy to spill over into just a fraud scheme. Next page. Next slide. So it's the increase of utilization. That's what folks are looking for in terms of from a compliance standpoint. And the learning point here is that from a compliance standpoint, it's really helpful to analyze where telemedicine was used and did it increase utilization? Because if it increased utilization, that's going to be a spot where regulators or payers are going to go look at the integrity of the compliance. So we have increased utilization, of course, is the fear of telehealth that payers have. And rather than saying, look, utilization increased because we're doing God's work, step back and say, okay, let's make sure we can paper and we can show that it's God's work, and and folks don't have to take our word for it. Donna, are we still, we just cleared questions in chat. Am I live? Can folks hear me? Somebody jump into toss me a chat if you would. Okay. It looks like Donna can. Can somebody in the audience throw a chat out there if you can hear and see? Great. Thank you, Kelly. Thank you, Michael. Where were we? Another red flag is massive revenue to new organizations. Again, if you've got well-established providers that are getting the massive revenue increase, then there's likely not big fraud. But if you've got multiple organizations being set up and all of a sudden they're getting massive revenue, then that's something that's going to flag, and that they're going to chase. And then fundamentally, and this is probably the most important compliance thing in telemedicine, and that is, what is the physician-patient relationship? It's just not thought of when people flip on the video and get to work, and that is, okay, I'm now your provider, but what am I your provider for? What is the scope of my care and therefore my responsibility? And what am I doing with you in terms of evaluation that appropriately establishes that physician-patient relationship, even if it's episodic? So a clinic manages patients along a continuum, and different providers come in at different points in time. Each provider has to think to themselves, okay, what relationship do I have with this patient right now? What's the scope of it? What should be their understanding? And consent is a really important place to plug that in. We'll get to that too. But in the big fraud, there's a questionable physician-patient relationship. Is looking at a questionnaire and looking at hundreds of them in a day or in a week, did you really establish a physician-patient relationship? And the thing that really bothers me about these particular schemes is that in every one of the press releases, there was the assumption that because the patients were never seen, that it was fraudulent. That wasn't one of the elements of the fraud necessarily, but it was and they didn't even see them. And I think that's incredibly dangerous, because there is good telehealth, as we've seen post-COVID or in COVID. There's really good care that's being provided when the physician doesn't lay eyes on the patient, telephone or whatever it is. So that's a really good way to reduce compliance issues, is to really understand the physician-patient relationship and systematize that, so that patients coming in to get certain care from a certain class of or group of providers gets the same consent, and that consent articulates what the physician-patient relationship is. And particularly, if there's not going to be follow-up, then it needs to be clear to the patient that the relationship is not continuing after that follow-up. And there needs to be clarity of where they should be getting their care, their primary care physician or from somebody, but I, as the provider, don't have a continuing relationship. If that analysis is done, then the integrity of the claim is almost guaranteed. Because to do that analysis and figure out the physician-patient relationships and the consent around that requires thinking about what is the claim for. and that then forces folks to go through a compliance analysis that is grounded in, okay, what's the physician-patient relationship? What am I getting paid to do here? What am I being expected to do here? Let's just go ahead and get that articulated now. Fraud schemes don't do that very well. I suspect they're going to get better, but they don't. And so that's a red flag. Next slide. So here's some specific examples. We've got, and these are specific to COVID-19. What I talked about previously was pre-COVID. Here we've got schemes to defraud healthcare benefit programs related to COVID-19 and genetic cancer testing. Then the Justice Department in August got a temporary restraining order against 3 defendants and over 300 websites purporting to sell scarce health and safety items. So you can see how this paradigm of telehealth that we live in just got twisted and tortured into 300 websites and 3 defendants. So it's a very discrete core group that was doing the fraud. But you can also think that if you want to confirm proactively the legitimacy of what the operations are of whoever it is that you're serving, you need to think about what each entity looks like from the outside. And if you're going to put together 300 websites to be able to get services out to the community, you need to think about whether that looks bad. I bet that was the most valuable thing I shared with you today. Okay, and then here we got a telemedicine CEO that pled guilty. That happened in October. And these were the 2 organizations that this CEO was running. Next slide. Okay, so I promised you direct-to-consumer integrity, and this is why direct-to-consumers like Doctors on Demand and Ameriwell and the white label direct-to-consumer platforms that healthcare systems are using. The reason why those have integrity is because they document legitimate medical purpose across a large patient population. And they're trying to increase access, not just for that particular visit, but to be able to care for a constellation of issues that patient returning might have. And it's not limited to just getting prescriptions for one thing or the other. And then there are physician visits that are unique for each patient inherently. So their medical records are set up with a quality assurance that the physician is actually engaging in the care of that patient. And to get to that, there's quality data analytics, there are policies across the platform, and importantly, direct-to-consumer does a better job, in my view, of getting really education-based consent, teaching the patient what they need to know in order to give consent. The direct-to-consumer folks have done that quicker, faster, and better. Next slide. Okay, so the future, we don't have a whole lot of time. I'm going to go 10 minutes here, if that long. But what's on the horizon? Next slide. So it's the permanent expansion beyond the emergency. As most of you probably know, the CMS has been very aggressive about saying that they want to permanently expand payment for telehealth. What that means is not clear, and it is certainly administration dependent. So what that's going to be in January and what the importance of telehealth is going to be, it was very important to the Trump administration, and it appears that it will be very, very important to a Biden administration. So telehealth kind of is seen as a solution regardless of your political affiliation. And so the politics are down to who's selling what in an open telehealth market. The home visits for evaluation and management got picked up, but what didn't get covered was the home visits from non-licensed providers, which of course is the vast majority of who we need to send out into patients' homes. And there's just been a lot of resistance to expanding out the full tale of long-term care. That's been changing. It's been changing by state, Medicaid, and otherwise. But there's still a long way to go to pay appropriately for telehealth services in the home. CMS is open for comments on what the services should be that should be added and why. And the Medicaid supplement that I talked about, the telemedicine tool that CMS put out for Medicaid folks, encourages states to expand all of these things permanently. Next slide. The ATA filed comments to the physician fee schedule, supporting a number of positive changes that are in the proposed fee schedule, but they wanted three things, and I think these are good bullets to think about. One is they wanted expanding access to more services and more providers. So you have a limitation. Many payers, as I was just talking about with home health, won't pay for certain types of providers or even certain specialties in terms of telehealth, and that needs to be revisited. Changes to remote patient monitoring services. Remote patient monitoring is not well reimbursed. It's not consistently reimbursed. Every Medicaid program's got a different kind of model, and it's becoming very vendor driven. But that I think we now have enough data, particularly with COVID, to be able to revisit some of those patient monitoring services and kind of clarify where the opportunities are there. And then telehealth and federally qualified health centers and rural health clinics is critically important. The importance of really focusing on the resources that these clinics need and the regulations that they need lifted in order to serve their populations is critically important. Next slide. So then we have the information blocking rule. Many of you must know that this rule was supposed to go into effect, I think, in August. Then it was pushed to early November, and now it's been pushed to April. And it prohibits unreasonable interference with access, exchange, or use of electronic health information. This butts up against Hipaa in a number of different ways, because the idea that patients can have complete access, well, the fact of the matter is that Hipaa lays out certain requirements for patient access. So we don't have a real apples to apples on many issues, but it applies out to IT developers and HIEs that were not subject to certain ones were not subject to Hipaa. And the fundamental thing here is that they want a new standardized API so that any vendor's piece can interface with each other, including the EHR. And it opens up the use of third-party software like apps. This has been really contentious. A lot of people are struggling with what compliance means with this, but at least the current administration has made it clear that this is not negotiable. They're going forward. Next slide. The CMS engaged in an artificial intelligence healthcare outcomes effort a year or two ago. The latest one here, they've got 7 finalists who are going to develop algorithms and predictive algorithms to do God's work from a health policy standpoint. And there's going to be prizes for that. What this shows us is less the prize or even the number of finalists as it is that CMS has used this method to try to get creativity and to try to get engagement from the health technology community to come up with artificial intelligence solutions. The FDA on their medical device side has really done an impressive job of developing their own AI for the regulation of medical devices. And that AI, particularly when it's fully rolled out, that AI developers are going to need to understand what those algorithms are and figure out a way to go with it. So there's a lot of power that regulators have when they begin to use artificial intelligence. Next slide. Here's a quick checklist in your. This is our last slide. There is a checklist in your materials from the Doctors Company, and Debbie Hill at the Doctors Company put it together. It's a great resource, and it's really simple, but it shows how you can categorize different things that need to be looked at from a compliance and operations standpoint during the time of COVID. Not just telehealth. Telehealth is a part of it, but it's one of the few places I've seen where there was a really good overall checklist, and it's probably more effective because it is, or even possible because it is specific to medical practices. But I think that you'll see that there's a lot of crossover to any provider because the principles are the same, and that is break down what you're charging for, break down how you're getting at it, and then put together your compliance program. Something to think about is that we need to be cognizant, particularly on the Part A and Part D side, so the hospital and the drug side. We have to be careful about the compliance of the physician with telehealth as it relates to what they ordered and the claim, the Part A or Part D claim that was made. So if the physician was not compliant, regardless of what they did with their pro fee, whether they billed it or not, or they billed it right or not, the question is, did they do what they needed to do in order to order the CAT scan, in order to do the admission? If there's a theory that telehealth could be used to do the 24-hour, the initial history and physical for hospitals. So it's really important that folks kind of think about not just the immediate care, but what is that then fanning out to? And then I commend the OIG work plan to you. They have been aggressive in articulating what they're going to be doing during COVID for months. And they're really clear, and it's really good. There's specific things to telehealth that really help you put things in a nice context. Next slide. Here are the resources that I promised you. That's it. So we've got some time. Does anybody have any questions that they want to tee up into our question box or throw into the chat? So while we're waiting to see if any of y'all want to visit this way, I want to invite y'all to reach out to me if you'd like to have a conversation one-on-one. This platform doesn't really help with that, and we've all got things to do, but at the same time, conversation is really, really important, and I appreciate that there's only so much I can do with a monologue, and I'm happy to visit with anybody or help anybody. My contact information is here, and Teresa Langley is an associate on our team who does a lot of telehealth and is the core reason why if this presentation has integrity, it's because Teresa helped me make sure that it does. So it looks like we don't have any questions and we don't have chat. So it's time to say goodbye. Thank you, everybody, for coming on. Thank you for supporting this important conference. And I hope this was helpful to you. Our next, I'm going to have to kick this back to you, Donna, but our next, because I'm not seeing what I did with the script, but our next presentation is going to be, here we go. So on behalf of the American Bar Association and the ABA Criminal Justice Section, thank you for joining us. Please join us at 12:10 Eastern on November 18th, a week from today, for our next session, which will be federal and state enforcement during COVID-19. So thanks again. I hope everyone has a wonderful day.